Good afternoon and thanks for joining us. I'm Judy Simpson. Over the past half-century, we've all experienced the tremendous advancements in medical care. We're living longer in large part because of new drugs and new surgical techniques, along with new technologies like medical imaging. But the advances in medicine don't come overnight. It takes years of research and trials, especially when it comes to preventing, diagnosing, and treating cancer. This afternoon, we're going to focus on the clinical trials in cancer research, and joining me are Drs. Jim Wallace and Steve Addis. Dr. Wallace is the leader of radiation oncology at the University of Vermont Medical Center, and he chairs the Protocol Review Committee at the Vermont Cancer Center. Dr. Wallace's primary role is taking care of men with prostate cancer. Dr. Addis is a member of the University of Vermont Cancer Center and an oncologist at the UVM Medical Center. Welcome and thanks for coming in.
Thanks.
Let's start with the basics, Steve. Maybe you could tell us what is a clinical trial?
Well, first of all, thanks for inviting Jim and I to come and talk today at Across the Fence about a topic that we're both very passionate about. A clinical trial is a research study in which gives us the opportunity to explore or address an important clinical question or a quandary either in the cancer world, either with respect to diagnosis or more commonly and more often treatment. Maybe a treatment void or offering us the opportunity to improve on a current treatment standard which may not be very good or which in some cases may not exist at all. And you know, our patients know, unfortunately, in the world of oncology, there are a lot of scenarios or situations, if we're talking about a therapeutic trial, say, or therapy, where the current standard of care is not that good, or in some cases may not even exist. And so patients and their families face a scenario where there may be no good treatments available for them. So let's say a classic scenario would be maybe somebody with an advanced cancer whose disease has relapsed after multiple standard treatments and whom they're facing a scenario where there are no standard treatments. And this gives them an opportunity to participate with all the safeguards, which we can talk about, afforded in a clinical trial, if we're talking about a therapy or a treatment they otherwise wouldn't have access to. And we consider this a core part of our mission at the University of Vermont Medical Center. So in a nutshell, it really allows us to advance the field, but it also gives access for our patients, if we're talking about a therapy trial, to treatments that they otherwise wouldn't have access to.
We should probably point out that there are clinical trials going on all the time.
Sure, there are lots and lots of clinical trials at the Medical Center. Many of them are trials that we've initiated on our own. Many of them are clinical trials that we've joined other groups with, and there are a number of national cooperative groups that we're very active in. I'm trying to answer some of the bigger questions where maybe you need 1,000 people, 1,000 patients to try to answer, is one treatment necessarily better than another treatment? The trials that we initiate on our own tend to be smaller trials where we have a concept we're trying to move forward and think about, and we can do so in a smaller world and then potentially bring it to the broader audience nationally, internationally.
And so who conducts the trials?
I would say just about every physician at the University Medical Center is somehow involved in clinical trials. And it's not just physicians. I think that's something pretty important to say. There is a huge team that's required to do clinical science, clinical research. There are research nurses, there are people involved in managing the data, there are people that keep track of us and make sure that we're doing is safe and legal and appropriate and ethical. There's a massive infrastructure to provide good clinical trial support.
And so who participates in the trials, and why would someone want to participate?
So I already mentioned one scenario. If we're talking about, we can give maybe best way to answer would be some examples. If we talk about somebody, let's say with high-risk prostate cancer, currently the standards of care to cure somebody with localized high-risk prostate cancer are good, but they're not great. There's a relapse rate associated with that. So for example, one of 2 or 3 studies that we have for such a population of patients will attempt to improve upon that standard of care. So in one instance, we have a study where a patient has the opportunity to potentially get a systemic therapy before they go to surgery to improve the cure rate for an eligible patient with a high-risk prostate cancer scenario. Or If that patient opts for radiation therapy, Dr. Wall is here, heads a study, a national study, and he's the local principal investigator on a study in which patients who are getting standard radiation will get an additional hormonal therapy in some situations, for a high-risk prostate cancer. These are very complicated decisions. So what ends up happening is you're sitting down with the patient and their family. You discuss the standard options, what they are, if they exist or not. And as part of that discussion, you're going to explore all the options. And clinical research should be on the table. And as Jim had mentioned, there are a lot of studies that are going on, certainly across the country, but also here at UVM Medical Center. We have literally hundreds of studies. Now, not all of them are cancer related, but many are. And as Jim said, some are homegrown studies. Others come from the opposite direction in our national cooperative group trials that are funded by the NCI. And our charge is to bring that to the patient and make it digestible and help them navigate those waters and decide, is this right for me at this time, given the array of options?
Are all trials run the same way?
Well, there's certain basic principles that apply to all of them. Mm-hmm. The patient has to be very well informed, and there's a very lengthy process of how to do that. There are investigators. There are, again, the people we've talked about before, the support group. But the common themes are, at least for the Cancer Center trials, we have to, and part of my work is making sure that these trials make sense scientifically, that they're asking an important question and one that we can potentially answer at our institution. And the other, is it truly ethical? Is this a question that we can ask without having biases? We could never offer a patient a trial if we honestly didn't feel that if we're comparing two potential treatments, that one or the other might be the right answer. Mm-hmm. So effectively they run the same way, although there are incredible differences from individual trial to individual trial, just because it can be quite complex.
Mm-hmm. And so are there common barriers that keep people from participating in a clinical trial?
There are lots of barriers. It takes a lot of time for the patient that we talk to and for those of us that are presenting them. It's very time consuming. Invariably, there are, as I explained to patients when I talk about trials, there are lots of hoops to jump through. If we're looking at a national trial, we want to make sure that everybody who's entering that national trial is starting in a similar place. So there's lots of testing. There are more questionnaires regarding quality of life, something that there's more and more research about than there has been in the past. So one of the barriers is time of the investigator and the patient. But other barriers, there's concerns and questions about being a guinea pig, mm-hmm. All sorts of potential barriers. But we work through them usually successfully.
Well, it's a pretty big responsibility for the patient, wouldn't you say?
It is. It's a decision that they shouldn't take lightly. It's actually a process, a decision to participate in a study. Another barrier is we obviously in Vermont is the distance. Patients travel either from upstate New York or from other areas in Vermont. Already they're traveling distances to come to us for their treatments. And in many situations they would love to have their therapies close to home. And I think part of the decision to participate in a clinical trial is a decision to potentially be having to travel much more frequently or much more frequent visits to a place that is far off from home. I had a study that was open for a number of years looking at radiation to the belly and the nausea it caused, and we were using several drugs to mitigate that nausea. Mm-hmm. The problem was you needed to get your radiation over here in order to participate in this study because of all the checks and balances that Jim was talking about and the coordinators and all the safeguards that we put in place for our patients. And understandably, a lot of patients, let's say who are coming from upstate New York, would prefer to get their radiation close to home. And so you have to think about those things when you're opening a study in a place like this. It may not be the right study for this population, but there is a process, and the process of going through and deciding whether a study is right for you involves, first of all, sitting down with us, going over all the options, placing the trial in the context of other options available to the patient and their family, then going down into the nitty-gritty about what the study is, what are the benefits, what are the cons, what are the potential side effects. Not only side effects if it's a drug, but as we talked about travel, we talked about cost. What are the safeguards in place for patients? What are their rights and responsibilities? And then what ends up following is we give them what they call a consent form. And the consent form really is written out in lay language, and it's really for them, for patients. It's not meant for us.
Right.
And we strongly urge patients and their families to take it home and sit down with a cup of coffee and read it through and own it and write questions on it and come back to us. And what I tell patients is educate themselves, and family members obviously, and if it feels right after going through that whole process, it probably is right. If it doesn't, I would tell them to trust their gut and say thanks but no thanks.
Yeah.
So it's not for everybody.
What are some of the types of clinical trials that you conduct?
So there are lots of different clinical trials specifically, and different places have different strengths. Our strength, we have a number of investigators who are very interested in identifying new agents, new therapeutic approaches, these so-called phase 1 trials, where you think something might be a good idea, but you don't really know how to apply it. Is it safe? And so even before you ask questions, can it be effective, you have to prove that it's safe, either in healthy individuals or other individuals who may or may not benefit from it. The trials that we traditionally start as individual investigators, so-called phase 2 trials, are trials where we actually try it in a population who we think there might be a benefit to, but we're not sure. And then the trials get into these bigger national groups where you compare what is the current standard to what we think might be an improvement upon that standard. And those usually take, for statistical reasons, frequently hundreds if not thousands of patients to prove one treatment's better than the other. So patients that we see have access to all of those trials. It's our piece or our place in those vary depending on our interest and our level of expertise.
How long do the trials usually take?
It varies widely. There are some, and it really frankly depends a lot on the nature of the disease and the question we're trying to ask. If we're trying to figure out in a disease with a very long disease course, say prostate cancer, and we're trying to find out if a specific treatment improves on their survival, those trials can take decades to come up with an answer. Whereas if we are looking at simply does a drug or a treatment make a tumor shrink, and it's a relatively rapid tumor that we know will have an answer in 3 months or 6 months, those trials can be completed in a couple of years. And given patients' participation also varies, but typically they are involved or enrolled in a trial for 3 or 6 months, but then the follow-up may last for years and years.
So we have a few minutes left. Can you touch on some of the types of research currently going on at the Vermont Cancer Center?
Yeah, so one example was we described before was in our realm. We both Jim and I treat prostate cancer. I'm a medical oncologist, of course. Jim is a radiation oncologist. So that was an example of those two studies. But we're also interested in the diagnosis of prostate cancer, I think there's a lot of understanding out there in the public that not all prostate cancers are created equal, so to speak. Some prostate cancers need treatment and others do not. And the PSA test, which everyone knows, is not a great test. And there's a lot of room to improve upon that. And so there's a lot of research going on, and these are collaborations between ourselves and basic scientists at the University of Vermont Cancer Center, looking at how we could stratify patients, how we could tease out those who really have the high risk or the higher risk cancers that really need to be treated versus those who can take an active observation or a watch and wait approach, which is a big diagnostic quandary that we face in prostate cancer. So to be specific, we have 2 studies going on right now, but I'll describe one in specific, both around the issue of diagnosis, in which we are looking at small snippets of RNA called microRNA, which we can profile in patients' blood. And we're trying to sort of read the tea leaves. We're looking at these microRNA profiles, and they appear to be associated with how aggressive the cancer is. And so right now we have a pilot study in which patients who are being diagnosed with prostate cancer, in addition to having all the usual tests they have for their diagnosis, are also getting blood drawn for this microRNA testing. And I'd love to say we're going to be able to circle back to those patients. That's not the nature of this sort of study. But what we're going to be able to do in about a year or 6 months to a year is look back and say, okay, let's look at the profile. Does this actually fit in a more aggressive cancer or not?
If people are interested in learning about more studies, where can they turn?
So there are lots of resources on the web these days. So the University of Vermont Medical Center has great information about specifically things we're doing at our institution. And then there are a couple websites. Clinicaltrials.gov is something that we personally use on a daily basis to see what other people are doing. And then the National Cancer Institute also has a website specifically related to cancer center trials.
Well, I want to thank you both for joining me today. That's our program for today. I'm Judy Simpson. We'll see you again next time on Across the Fence.